So we are given with a revision class, review class of the contents, whatever is going through in the pelvis. I'm just like sticking to the basic regions of the pelvis where you should be focusing on for the preparations, both in the practical and theory. And this particular pelvis is kind of little bit complex whenever it comes into understanding the space which is related to the abdomen, pelvis, and the space which is lying below, we call them as perineum. So that's why I projected this particular picture. This is an age-old picture to figure out these body cavities that we have. Now this particular body cavity which is above this diaphragm, we have called them as thoracic cavity. Below that, which is shaded in the pink, we call them as abdominal cavity. Now this particular abdominal cavity, as it moves down to this hip bone region, we give a different shades which is also continuous with this abdominal cavity proper, but though we separate it with a special name, we call them as pelvic cavity. Now this particular pelvic cavity, which is limited at the lower part by another partition, we call them as diaphragm. So we have a partition out here, we call them as the diaphragm or thoracic diaphragm. We have a partition below which is limiting the lower limit of this abdominopelvic cavity, we call them as pelvic diaphragm. Under this pelvic diaphragm, we have a tiny small strip of tissue or space there which is shaded in the orange. This particular space in orange you are seeing here, we call this space as perineum. So this particular concept of abdominal cavity, pelvic cavity or abdominal pelvic cavity, and separated by this lower limit by this particular pelvic diaphragm, and this perineum is important. If we just draw a cross-section picture, if you draw a cross-section picture, if you're looking into it, we find this particular same space. Abdominal cavity, pelvic cavity, perineum, which is lying below, limited by this particular partition, we call them as pelvic diaphragm, which is we are going to talk here. Now, this particular pelvic cavity can be divided off two parts. So we divide this pelvic cavity into three parts. We call them as the greater pelvis, which is continuous basically with this abdominal cavity, and which is limited by this partition, imaginary line, we call them as pelvic brim. Under to it, which is limited by this lower part, by the pelvic diaphragm, we hold a space, we call them as true pelvis, also known as lesser pelvis. Now this particular region brings out this particular term, we call them as pelvic brim. We have to understand what is pelvic brim. Pelvic brim is this imaginary line which we draw starting from this midpoint over here, we call them a sacral promontory of sacrum, iliopubic eminence, pectinate line, and holding into this particular line, we call this as symphysis pubis, and this region which is continued down on the other side as well. So this particular red line which you see here is representing this particular point, we call them as pelvic brim. Now this particular pelvic brim, above that and below there we have two different districts. Above we call them as greater pelvis, and below there we call them as true pelvis or the pelvis, which we are going to study. Now this particular region brings us this particular region, we call them as pelvic brim, which is this dotted line represents. So often during examination we ask about pelvic brim. Many a times we get like a 50% answer to it. What do you mean by the pelvic brim? What do you mean by this pelvic inlet, etc., etc. We do not have a proper idea whenever we are asking about it. So this particular pelvic inlet or pelvic brim is a synonymous thing which is imaginarily splitting this pelvic cavity into above greater pelvis, below true pelvis or the small pelvis. So this particular line we call them as pelvic inlet, which is getting this into the pelvic cavity. Now if you are getting inside the pelvic cavity, there is an outside line there, we call them as pelvic outlet. Now compare with this pelvic inlet, which is all surrounded by the bones. If you look at this particular pelvic outlet, this particular thing has this particular anterior or anterolateral made by the bone. Posterior side, we do not have any bone covering, rather which is fused over by a ligament which is present in here, we call them a sacroiliac ligament. That means it's a ligament coming from the sacrum going to this bony point, we call them as ischial tuberosity. So this ischial tuberosity into which we are sitting, we have a ligament crossing over here, completing this particular pelvic outlet. So this particular pelvic outlet is made partly by this particular thing we call this bone, and this is made of ligament or soft tissue. Gives this pelvic outlet its stretchy structure. So if you are stretching, this can get wider. Comparing with this pelvic inlet, দেখে যায় একটু পিছনে যা আরেকটা লাইট যা compare with this particular pelvic brim, also known as pelvic inlet, is completely surrounded by this particular bony cavity, gives this particular pelvic inlet a little roominess whenever it is required to stretch. Now when it is required to stretch, we are coming into it. That particular thing matters. Now moving to next one, to this particular joints which is involving here. That side we have a joint, we call them a sacroiliac joint. Front side we have a joint which is between this particular two hip bones, we call them a symphysis pubis. The nature of two joints that you have to keep in mind. On the back side, sacroiliac joint, right side, left side, they are synovial type of joint. That means it allows some kind of movement. In here, anteriorly, we have a cartilage present inside. We call this cartilaginous joint, and we call them a secondary cartilaginous joint because this particular cartilage remains cartilage throughout life. If this particular cartilage gets fused, mixed bone, we call them as primary cartilaginous joint. So this particular thing which is brings over here about this particular measurement of this pelvic inlet, we call them as diameters of pelvic inlet. It matters to us. Well, for this particular region, this is holding the childbirth passage. So this fetus runs through this particular pelvic cavity and gets out of the pelvic cavity. Now, if it is entering to the pelvic cavity and running through this particular pelvic canal and then it is coming out, this particular thing has to encounter through this particular opening. Likewise, this opening, it has to enter through pelvic inlet, then it to run through this particular pelvic canal, then it has to move out through this pelvic outlet. Now, out of these two, inlet and outlet, we already have agreed this outlet is stretchy one. That means it's made of ligaments in the posterior legs. That means if it is pushed on, pressure through it, it can stretch. Compared to this one, which is all bony, do not allow that stretchiness. So this inlet diameter matters to us whenever we are considering for a childbirth prognosis. So if that particular product of conceptus, the fetus, present or growing in uterus, growing big, reaching to the appropriate age, are going to be successfully running through this particular birth tract and normally exiting or not, or we have to go for surgical interventions, just like surgery of this region, we call it cesarean section or not, this diameter matters to us. So this diameter, measuring this particular inlet diameter, we call them as conjugates. So this conjugate, we measure this narrowest point of diameter between here, between this particular symphysis pubis to this particular point, we call them a sacral promontory. So this diameter which you are measuring here, we call them as conjugate or anterior-posterior diameter, also known as AP diameter. Now, out of these AP diameters, we can measure this into three segments. So if you look at this particular picture, which is down, we can just like measure this particular anterior-posterior diameter from three landmarks. One is under the symphysis pubis to the sacral promontory. This is one which you see here represented by this green line. We can measure this from top of the symphysis pubis, go to the same point over here, sacral promontory. This is black line which you see here. And this, which is lying in the middle point of the symphysis pubis and measuring to the sacral promontory. We get three measurement lines which is present in here. So these three lines which are representing this particular anterior-posterior diameter. Now, out of these three lines, green line, red line, and the black line, the least diameter we are getting in here, which is the red line, which is known as the AP conjugate. We call them as true conjugate, also known as obstetric conjugate. Now, this particular obstetric conjugate, we measure that for the childbirth prognosis. Whether we are going through surgical interventions or we are going to let this particular baby come out through the birth tract or not, that measurement matters. How? if this red line, which is known as obstetrical conjugates, which is narrowest of all these three AP diameters, is more than 9.5 centimeter, we allow this particular baby to go through the birth tract, because we know that this will be coming out. Now, why 9.5 centimeter? Because the maximum healthy, the maximum diameter of this particular brain, which is measured from the right parietal eminence to left parietal eminence in a normal healthy babies, is 9.5. So if this particular measurement is more than 9.5, we allow this baby to pass through. Or else, if it is, say, for example, measuring through here, if you get this particular 8.5 or 9, that means if this particular baby head passes through it, it will be crushed. There will be chances of, or very high chances of, brain injuries. We do not allow that thing. So for that reason, we measure this particular diameter beforehand. Clinically, next one. Clinically, like measuring this, we call them a digital fingerimetry for this measurement, or digital measurement, or ultrasound or MRI. Doing this, we measure this particular green line, which is obstetrical conjugate. If you get this measurement value more than 9.5, then it's good. If it is 9.5 or less than 9.5, we just like a go for cesarean section. So that's why this particular diameter assessment is important for us to measure this, about this particular diameter which we are going through. Now, we are going to talk about this particular pelvic cavity. We know about this particular pelvic cavity, which has got like a borders or walls. It has anterior wall, posterior wall, two lateral walls, right side, left side. Anterior wall is made of bones, which you can see that symphysis pubis, and this particular bone which is extending to this iliopubic eminence, etc., etc. Posterior side, we have the sacrum. Back side, we have this particular coccyx as well. Lateral side, which is formed by this particular hip bone, continues over there, and the muscles over there. And then we have this lower limit of this particular walls, we call them as floor. The floor, which matters to us. The floor, we call them as the pelvic diaphragm. So which we will going to learn in detail about this. So move through. So this lateral wall is formed by this particular hip bone. You are seeing this particular lateral side of the right side taking over from this side. This side we have this particular muscle which is there, which is lying over this cavity. We call them as obturator cavity or obturator foramen, which is tested by this particular membrane, obturator membrane. On top of that, we have a muscle, Obturator Internus, which is covering this, and a ligament present. We call them as sacrotuberous, which is running from sacrum to tuberous, ischial tuberosity. We'll see this sacrotuberous, sacrospinous ligament in detail about this, how this particular thing is there and what it matters. So this is forming the lateral wall out here. This muscle which is present in the lateral wall, Obturator Internus, matters to us because it is making this particular wall covered with this membrane along with this particular muscles on side. This wall which you see here, this is a posterior wall. So this posterior wall is made by the bone, sacrum, and below there we have this tailbone, coccyx. Then we have this muscle which is present on top of it. We call them as piriformis. So this particular piriformis, move forward. This particular piriformis which is present in here, and this particular obturator internus which is present in the lateral wall as well, they have very close intrigue relationship. How they are intriguingly important? See that both of these particular muscle, piriformis and as well as obturator internus, you are seeing this is on medial view section. This is the posterior view, what you are seeing in here. Both are dating from the lateral wall and the posterior wall and directed to this greater tuberosity of this femur bone and plunging into this particular region. So they are present on the back side of this particular hip joint, and this particular muscles, piriformis and obturator internus, they are present, and whenever they are contracting, they are making this hip rotate laterally. They are lateral hip rotators, they are present. So even though they are coming from two different walls of this like pelvic cavity, they are merging to a point or ending to a same or near same point. So that allows this particular two of the muscles being placed in two different walls of the pelvis but doing the same actions in this particular regard to the actions of it. So these particular muscles, piriformis and this particular obturator internus, we have dissected that in the lower extremity classes. In the gluteal region, we have seen this piriformis muscle, which is known as the key muscle, and this particular muscle, tendon of obturator internus, which is present as the content which is lying and the pin structure which is lying below that. So these two structures, we have seen that in this particular hip region, and we have tagged that particular muscles many a times for identification because they are very important muscles altogether. Coming to the ligaments that we are referring in here, we have two ligaments to consider over here. We call them as sacrotuberous and sacrospinous. They are very important ligaments in terms of presence in this particular pelvic region over here. So we have sacrotuberous ligament exiting from this particular sacrum and ending on the ischial tuberosity, making this particular region over here. So sacrotuberous, and there is a tiny ligament which is present in this ischial spine and ending into the sacrum. They are known as sacrospinous ligament. So these two ligaments, you can see close, they are converting the greater sciatic notch and the lesser sciatic notch into the foramens. We call them as greater sciatic foramen and lesser sciatic foramen. So these particular foramens in the dry bones, we see that as a notch. And these things are converted into the foramens by the presence or attachments of these two ligaments. In examination, again, we ask about this particular thing, about how this particular notches is converted into foramens. And we get a 0 answer during the examinations because you guys think you are too smart to understand this. And in your examination, you end up losing your marks. Again, so this particular greater sciatic foramen and lesser sciatic foramen, they are kind of important whenever you are considering the structures which is related to the piriformis. So this particular region is laid over the piriformis muscle, as you are seeing here, splitting this particular region. This region over here, we see these structures exiting this space above the piriformis, below the piriformis. We ask these questions about this again. So what are the structures releasing or getting out of this region above the piriformis and below piriformis? Why? Because we are full. We ask this question. We want to make it full. No, this is important because this region, we do a surgery. We do a surgery over here. We call them as hip joint prosthesis surgery. Again, we come into this particular space. When you do surgery in this particular space, we negotiate with these structures. And we mess up with the structures, we land up into big soup because we have this nerve which is coming over here. We call them as internal pudendal artery, pudendal nerve, which is running in this region. If you damage this, you lose the vascularity of the whole of the perineum. And the whole of the perineum is basically supply all the genitalias. So we lose this particular nerves, we lose this particular muscle, we lose this particular blood supply to it, we lose the functional utility of the perineum. Why this perineum is important? We are moving into this floor region. So this is the lower limit of the pelvis, which is formed by this pelvic floor. We can also call this as a pelvic diaphragm. Now just like the D diaphragm, which has two domes of the diaphragm, right dome, left dome, and central tendinous part, this particular floor of this region also have two components. We call this as a coccygeus component and levator ani component. So this particular pelvic diaphragm is made up of two muscles, levator ani component and coccygeus component. So that's why we say that levator ani plus coccygeus with this coverings on top of it, we call them as this particular region having this particular peritoneal fold, soft tissue covering together makes this particular floor of the pelvis also known as pelvic diaphragm. So the pelvic diaphragm is your exam short note, which is coming most of the times during examination. Now, during this pelvic diaphragm, what you have to understand, this particular pelvic diaphragm is not a continuous stretch which is present. It has a natural opening which is present within this particular pelvic diaphragm. There is a natural gap that is present in the anterior part of this pelvic diaphragm. So, posterior to this symphysis pubis, we see this region, we have this particular content of the structures passing through. What is passing through? We have seen this urethra anteriorly passing through. Then we have this vagina, which is passing through in the female subjects. In case of this both of the sex, we have this rectum, which is passing on the back side. To allow this passage of these three important structures, this floor of the pelvis or pelvic diaphragm has a natural gap existing here in the anterior part. So this anterior part opening or natural gap which is present, we call them as hiatus. So we call the hiatus as hiatus urogenitalis. That means it's passing this urinary system content and as well as the genital system content through this natural gap going through. And the muscles which is present in this particular pelvic diaphragm, they are wrapping or bridging in this particular region, covering this region. Now, how this particular pelvic diaphragm is oriented over here, this is the sagittal section which you are seeing here. And then we have to understand the muscle fibers that is present in the levator ani and this coccygeus. So if you see this particular picture, this is a picture which is given over here is a male half and the female half joined together. Now this is the anterior side, this is the posterior side, and the subject is lying on the lithotomy or childbirth posture. And you are looking from the front side of it. That's how you are orienting yourself. This is not in anatomical position that you are judging in here. So this patient is lying down in lithotomy position or childbirth position, and you are standing in front of it and you are understanding these regions of the muscle orientations here. Now this coccyx, which is a landmark. So all the muscles which is present in the levator ani or the pelvic diaphragm runs between the symphysis pubis to this coccyx. Now we have the hip bone which is present, and we have this particular hip bone, three components are there. So muscle fiber from this particular front bone, we have the pubis which is ending on this particular coccyx. We call them as pubococcygeal fibers. The muscle fiber which is present on the ilium bone, which is running in the middle fiber, we call them as iliococcygeal fiber, which is coming from the ilium bone to this particular coccyx. So this levator ani have the two basic components, pubococcygeus component and iliococcygeus component. The third one is coming from the coccygeus, which is lying on the back side, which is present on the posterior side. So basically, summarily, this particular pelvic diaphragm is made up of two component muscle, levator ani, coccygeus, also known as ischio-coccygeus. Levator ani is composed of two group muscle, pubis to coccyx, ilium to coccyx. Now this pubococcygeus, which is running from pubis to coccyx, can be divided into subdivisions like this: pubo-vaginalis, pubo-analis, pubo-analis, pubo-perinealis, and pubo-rectalis. These are the different muscle slings that is coming front to back, holding these organs into this region. What are the functions of this? These actions of the pelvic region is that pelvic diaphragm is holding this all the organs which is sitting on top of it whenever you have increased intra-abdominal pressure. When you have intra-abdominal pressure increase, coughing, sneezing, defecations, micturations, all this time, or doing something, exercise, etc., etc. When you have this abdominal pressure is mounting high, this particular muscle contracts and leaps. That's why it is known as levator. So when this particular muscle is contracting, it is moving up. That's why we call this as levator ani. It is holding these things up. So whenever this particular muscle, you are seeing that backside here. পিছনে যা একটু পিছনে যা পিছনে যা আরো পিছনে যা আর একটু না সামনে আয় সামনে আর একটু সামনে whenever you seeing this particular muscle orientations, this is what you are seeing here. They are lying like a sling. So this muscle contracts, the lifts up. That's why they are known as levator ani component or levator ani muscles. So these are the different muscle fibers. They are encircling around the hiatus urogenitalis, and we give these names like puboprostaticus, puboperinealis, puborectus abdominis, puborectal fibers. So we have the fibers out of this particular levator ani, which is surrounding, which is surrounding this particular rectum anal canal and making a sling. We call them as puborectal sling. So this muscle fiber, which is slinging around this particular rectum anal canal junction and making a sling like that, so we call them as puborectal sling. Now what is the functions of the puborectal sling is there? This is present between this particular rectum and anal canal junction. And this particular muscle contracts, makes an angle acute between this rectum and this anal canal. So whenever this rectum is filled up with this fecal matter, this particular thing drops down. And as a result of that, we have this particular chances of rectal prolapse is there. So that's why this particular sling is passed on to make an angle in this region. So this particular sling, which is the fibers of the pubococcygeus muscle, which is slinging around the rectum anal canal, we call them as puborectal sling, contracts and making this particular angle over there. If we lose this angle by any chance, we have a chances of rectum to dropping into the anal canal. We call them as rectal prolapse. When this happens, in case of the children, these muscles are not developed. So in case of the children, if they pass too much of stool by any kind of abdominal diseases, this rectum prolapse happens. So children comes more often with the rectal prolapse. In case of old age, these muscle fibers are worn out, weak, resulting in loss of angle, resulting in rectal prolapse. We get this rectal prolapse more in common in female, in kids and in old age individuals. Explain why with your anatomical knowledge. So this is what you have to explain it, why this is more common in children and why it is more common in old ages. Other regions where this particular pelvic diaphragm or this particular muscle fibers can be stretched or can be damaged. So this is what we are seeing here is a pelvic diaphragm, and we are seeing this considering these fibers which is present in here. So normally this particular muscle fibers in case of the female subjects are of no threat. It becomes a threatful condition when this particular individual goes through pregnancies, and that if the pregnancy continues as a normal childbirth. So if we have the normal childbirth going on, the fetal presenting part plunges to this particular pelvic diaphragm, stretching it wide, leading to tearing of these muscles which is present in here. So if you have a tear of this particular muscles which is outmost are more threatful over here is the middle fibers. What middle fibers there? We have this pubococcygeal fibers present in the midline. So these pubococcygeal fibers are more often get teared in childbirth process. Then we have a natural chances of prolapses in female subjects after childbirth because of the damage to this particular flow of this pelvis or pelvic diaphragm. Again, explain why. After childbirth, more commonly we see this incidence of different types of prolapse, rectal prolapse, uterine prolapse, cystocele, etc., etc. So this is what we have to understand why this particular female subjects are more prone to have stress on this pelvic floor, and what happens if we have stress on this particular pelvic floor, injury to it, leading to the diseases. We call them as injuries out of or stress incontinence or any form of prolapse, etc., etc. So these are the things that we have to understand related to this particular pelvic diaphragm, because this is a very high yield exam question. Short note wise, pichone jao. Over here, just over here we see this particular giving examples of these regions, like again same fibers gets damaged over here. Puborectal sling, which is the midline fibers, which often gets damaged during this particular childbirth as well, leading to post childbirth this incontinence of the rectum. We call them as a rectal prolapse, etc., etc. So these are the entities that we have to keep in mind related to this particular clinical problems in this particular pelvic diaphragm or pelvic regions, which is the organs are concerned. The prime functions of this particular pelvic diaphragm is to hold the organs whichever is present in here. Just like it holds this urinary bladder, it holds this uterus along with this vagina, it holds this particular rectum, and piercing through this is the anal canal is coming out. Through this natural opening, which is known as this particular hiatus urogenitalis, that is a weak point. Now, if we have damage further leading to this fiber damage of these pelvic floor muscles, we have more chances of prolapse or further complications which may arise out of it. So that is all about this particular recap part or revisions things which is related to these regions. I'm not just like going any farther beyond that. I hope you can just like read on your own rest of the contents, like the arterial supply of this region, which involving these particular blood vessels, which is arteries. Arteries over here, we have this internal iliac artery, divisions of that, anterior division, posterior division. What are the sub branches coming out of this particular anterior and posterior divisions of these regions, and their clinical importance, of course, you will be learning. And focusing on this region, we call them as internal pudendal artery. Internal pudendal, move forward. This internal pudendal artery, we have to just like learn it in detail. Move forward, move forward, move forward, move forward, move forward. Because this internal pudendal artery is the only artery that supplies this particular perineum region. So this is the sole blood supply on the perineum region. If you lose this internal pudendal artery during surgery or any kind of trauma, we have this particular whole of this lower part of the body, that means the perineum region, loses this utility and the functions. So this internal pudendal artery, the functions and the supplies will be coming in whenever you are studying this particular perineum region. Read that in detail about that, and branches of the internal pudendal artery, its anastomosis related to this rectum anal canal. Prepare that really well whenever you are preparing that. So that's all for the day.